So record on this. Okay, and let's start share my screen. Okay. So Sarah, why you are late? It's 5 minutes now. Okay. Okay. So welcome for the first session. Very happy to be with you all. Now you might find me a little bit rigid, but I'm very flexible with the nurses. But I'm more, for me, patient is a priority. So discipline are very important. Therefore, your timing is very important. So being late is not something good that I like. Okay, now, so our agenda today, we will go through identifications. We'll talk about how we present the history of the mother and how we write the delivery room history and how we write arrival of the baby to an ICU and PICU and how we create our active problem list and how we create our resolved problem list, and then how we present CNS, which is the central nervous system, how we present respiratory system, how we present cardiovascular system, and gastrointestinal tract and genitourinary system, how we present infection and hematology, how we present the referrals that we did or it had been done, how we talk about the social part of the patient, and then we will put our nursing assessment and what is our plan. Now, am I fast or slow, or you have a problem in my English? No
It's
answer?
okay.
Okay. So what is a nurse job in pediatric and newborn intensive care, PICU and NICU? Well, your first job is to monitor. So you monitor the baby, and when you have a problem, you report. And to report appropriately, then you have to document appropriately. The second part of the job is you care the patient. You care the patient need, and you care the patient medications. So whatever the patient need, you have to care about. His pain, his conscious, his vital signs, his systems, his life, his food. You have to care about the baby. Okay, that's your second job. Your third job is to advocate for patient. So if the patient is suffering, or if the patient is not responding, or you think the machine are hurting the baby or the child, or you think somebody is a little bit aggressive or not safe, even as doctor, that's your job to be patient advocate, to be against that. Fourth part of your job is to execute orders. And when we say orders, we're talking about medical orders. You don't execute any orders because you're not servant of anybody, but your job is to execute medical orders. And medical orders, there are many, we'll talk about it, whether it's a verbal or written. Okay? And last part of your job is to present yourself and to present your patient. Okay, so how we determine the identification of patient? Well, there are many identification that we use. First, we use the, for example, singleton or multiply. So it can be twin, can be triplet, can be quadruplet. Okay. So today I will allow the admission after I start, but next session I won't allow it. Okay, today DR is late, Mariam is late. Okay, the other part of indication is the MRN. Sakar also is late. So the MRN, whatever the naming, also the gender, whether it's a male or female, it's identity. Also your gestation at birth. And when we say gestation, we don't say it week only. So we say 29 plus 0 out of 7. So it's important to write it in this way. Okay? Or we can 29 plus 1 out of 7 days. We always say gestation at birth. Then we say age of life. In the first day, we say it hours. And then after the first day, we say days of life. And then we have to say the corrected gestational age. So 18 divided by 7, that will be 2 plus 4. Okay, so 2 plus 29, that's 31. 4 plus 0, I think I'm wrong here. It should be 21, 31 plus 0. Now it's very important for us to know what is the 0 day, or is there a 0 day or not. So when you practice with me, day 1 start by midnight. Day 1, anything before midnight, it's called 0 day. So if the baby born at 2 p.m., his first day start at midnight. If the baby born at 6 a.m., his first day start at midnight. So always midnight is the day 1. And the second midday is start day 2, and so on. Anything before midnight considered 0 date. So always when you document, and the doctors also have to know that. Do you have any question here?
No. Doctor,
Okay.
sorry.
Go ahead.
Sorry for interrupting you, but there's another friend wants to just join the Zoom.
Another friend want to join the Zoom. Who is that? Who's that friend?
Sumaya, but she doesn't, and she can't.
Well, she did not. Which one? Because remember, if there is no name, I won't allow to enter. You have to write your name. So she has to click on the link, and then I allow it. Without she clicking or he clicking on the link, I won't allow to anybody. So there is nobody is waiting in the room. All joined. You understand?
She said that
So
I click it, but I can't join.
You are joining. You are already in. That's why you speak with me.
Not me. My friend.
Okay, who want to make? What is the name?
Sumaya Jum'a.
Sumaya Jum'a. She has to click on the link.
Okay, I'll tell her.
Yeah, you need them.
Thank you.
Because nobody is on the waiting list.
Tom, thank
Everybody
you. I'll
is
tell
in.
her.
Yeah. We also need to say the birth weight, and the birth weight should be by grams, not kilogram. Also, we say the current weight, and we have to weigh the baby daily. And we have to know whether the baby gained or lost weight from the yesterday weight. We also have to know the working weight. The working weight is usually, most of the time, is the birth weight until the baby passed the birth weight. And usually they pass the birth weight by day 7 or day 10. So usually the working weight is the birth weight until the baby passed the birth weight. And we use approximation, okay? And we approximate to next 100. So if your weight is 1,050 grams, what is your working weight? Anybody? If your birth weight is 1,050 grams, what's your working weight? We approximate to next 100. So if your weight is 1,050 grams, your working weight is 1.1. If your weight is 789, your working weight is 0.8 kg. If your weight is 30 grams, your working weight is 1.3. Now, do you understand?
Yes, it's clear.
Okay. And then is target weight. Okay. Sometimes the working weight, we use it. That's the decision of the team. When we have edema, we might use lower weight. And when we are dry, we might use higher weight. So the target weight usually is the birth weight approximated to next 100, or sometimes we use higher or lower, depend on the patient condition, if there is edema or dehydration. And we should also write what is our target weight. Where do we take the baby? And usually the target weight is the 100 grams plus the working weight. So when we are 1.4, we want the baby to be 1.5. Is it clear, the identification? That's what you need to mention every day in the morning. Any question here?
Sorry, but I didn't get the target weight. What do you mean exactly, Annie?
Target weight is where we want the weight of the baby to be. So most of the time we want the baby to gain weight. Okay? So our target is to make the baby 1.3. Once the baby become 1.3, we want the baby to be 1.4 and so on. So that's our target weight.
Thank you.
Because you will see when you work with me, I am obsessed with the weight gain. If there is no weight gain, then there's something wrong. So it's very important for the baby to gain 20 to 30 or 40 grams per day. Okay?
Okay, we get it.
Questions? Questions? So these are everyday morning identification. So first,
Could
you
you
will
please
never mix.
repeat the working weight?
The working
Could you
weight
please?
is the working weight is the weight that we use it for calculation of fluid, food, medications, and it's usually the birth weight until the baby passed the birth weight. So you can see the weight of the baby here, the birth weight is 1162, and the current weight is 1183. So usually we use the current weight. However, we cannot use 1183 to calculate medications. So what we approximate to next 100. So you can see 1183, the next 100 is 1200, 1200 grams, because the current weight is 1183. So let's assume the current weight is 1205. Then the working weight will be 1.3. Let's assume the current weight become 1362. Then the working weight will be 1.4. And the target weight will be 1.5. Okay?
Okay, clear. Thank you.
Okay, so it's very important. It's very vital in newborn babies. Very important to stick to this routine, you and the doctors. Okay, and then we need information about the mother, especially in newborn babies. It's very important to know the gravidity, G5, parity, P3, abortion, abortion 1. It's very important to know the mother blood group. Now you say, if you don't know, you have to mention mother blood group is unknown. Okay, you cannot just leave it. Then we need to know the HIV status of the mother and hepatitis B virus, whether it's negative or positive. And it's very, 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 very vital to know whether the mother was in labor pain during delivery or not. Because pain, one of the causes of pain is infection. Okay, so it's very important for me to decide whether to give antibiotics to this baby to know if the mother was in pain. Okay, I cannot allow Zoom user to enter in. Today I will allow. but next I won't allow. So please change your profile name to your full legal name. Also, we need to know the rubella status of the baby, whether it's reactive or non-reactive. We need to know also whether there is a prenatal ultrasound, any family history of any problem, obstetric history, whether hypertensive or diabetic, whether twin or not, something like that, whether the mother developed seizure or not. So please, Zoom user, your profile Zoom user, you need to change your name, your profile name to your real name. Also, you need to mention the delivery history. So you can see the mother delivered by normal vaginal delivery. No active resuscitation was done. And when we say active, we mean we use ventilation. Ventilation by hand, so we bag the baby by hand. Ventilation by CPAP. Ventilation by other machines such as a new puff or T-piece or even ventilator. So no active resuscitation means that this baby did not receive any support, neither by hand nor by machine. It's very vital to know APGAR score. And if you say, oh, I don't know the APGAR, you said APGAR score is unknown. Okay, and we need the very important to calculate the APGAR score. Now, you have to know also, you keep counting APGAR score until the score becomes 7. So if you have the score at 5 minutes, 6, you have to do it at 10. If you still have it 6, you have to do it at 15. If you still have it 6, you have to do it at 20, and so on. So you continue APGAR score until your score 7 and more. Okay? And when we write, we have to write the notes like an RP. Do you guys know what is an RP? Hello, guys? Do you know what is an RP? Anybody know what is an RP?
Activity follows.
Either you know or you don't know. Please tell me. Anybody knows what is an RP?
I don't have an idea. I don't know.
Okay, it's neonatal resuscitation program. It's neonatal resuscitation program. I will give you a session about it, and then we'll do hand-on and we'll give you a certificate of NRP. Some countries use NLS. NRP is from American Heart Association all over the world. You cannot work in an ICU without having certificate in NRP and expired after 2 years, so it has to be renewed. Okay, so when you write the resuscitation, you or the physician, it has to be steps as NRP, and usually it's a block of time of 30 seconds. And then you need to tell me during the morning who attended the resuscitation, which doctor and who did the resuscitation. Is it clear about the delivery and resuscitation notes?
Yes.
Okay. Next, you need to list to me what is the resolved problem of this baby. So if you remember this baby, our example is 15 days. So he had RDS and it's resolved. And we did sepsis. People here said septic workup, right? You said that? You always say that? Septic workup. Is that right? Do you guys say septic workup when you do blood investigation, right? So it's not septic workup, it's sepsis workup. Septic workup mean your workup was dirty. Sepsis workup mean a blood work for a patient who's suspected to be sepsis. So remember how to write sepsis workup, not septic workup. Okay, so sepsis is ruled out, mean that the baby had a blood culture, had CBC, and he received antibiotics for 48 hours. and then we stopped the antibiotics because we ruled out the sepsis. So he has resolved RDS, he has sepsis ruled out, he has metabolic acidosis that resolved, he has jaundice, received phototherapy and resolved, he has anemia of prematurity, resolved either spontaneously or we gave blood. He has resolved thrombocytopenia, either spontaneously or we gave platelet. And this baby has resolved Klebsiella pneumonia conjunctivitis, okay, because we gave oral eye drops and then we repeated the swab culture and the culture was negative. So any question about the resolve? For example, if the baby become 37 weeks, we said resolved prematurity, something like that. Any question about the resolved problem list?
There is no
Now,
question.
sometimes you don't know the list, so you have to ask. Okay, ask the doctor, what is the problem here? Which one is resolved? So you have to discuss and write it. And then you have to tell me the arrival status. Okay, so we will talk about transport, sending the baby as a sender and also as a recipient, what exactly you wrote. So you need to write full prescription, mainly the vital signs. And you need to mention the temperature, the blood pressure, the saturation, the gas, the ventilation, the medications, what was the arrival status, and who was with the baby, which nurse and which doctor, and what was the condition of the baby, who was reasonably stable on support, he's not. What are the lines, peripheral or central? What's the vital sign? What's the list of medication and doses? What is the devices connected to the baby? Pumps, the number of the pumps, the ventilator, any other device connected to the baby, and what are the monitor, cardiorespiratory monitor, near-infrared spectroscopy monitor, saturation monitor, and so on. So in arrival status, you need to list it exactly what was the condition of the baby. And with time, when you work with me, you will learn more. Once you make something wrong, we will correct, and so it's a learning process. Any question about the arrival status? Okay, no question. Let's go for it. And then we need to list the active problem list. So this baby actually twin. He's premature. He was born at 29 weeks. He's low birth weight. He has apnea of prematurity, feeding intolerance. He cannot tolerate the feed. Okay, he has culture negative possible Klebsiella pneumonia sepsis because his eye have conjunctivitis and he has thrombocytopenia, and the other baby died because of Klebsiella pneumonia sepsis. So these are the active problem list. And now we go to CNS. So in the CNS, the most important is to write the current and what are we planning to do. So most of time I do head ultrasound, and I do the head ultrasound for a premature baby at day 14 for any baby born before 32 weeks. And if it was done, because he's 15 days old, we need the findings. And if it was not done, why it was not done. Whether the baby is in the sedation, giving or not, dose and type. And because you need to do the pain score. And usually I use the SNP, and then I will teach you what is the SNP and how you do the pain scoring. And whether the baby is on caffeine straight or base, because you have two types of caffeine, giving or not given, whether baby receive load or maintenance or mini load. Okay, and if the baby has any abnormal movement, present or not, treated or not. Abnormal movement can be seizure, non-seizure. Whether the baby has ROP or not, retinopathy of prematurity. And usually we do the screening by ophthalmologist at day 31 or at life of 21 days if the baby is less than 27 weeks. Is the hearing test done or not? Well, is the metabolic screen? We don't do here in Erbil metabolic screen, but I'm hoping that we can implement that, done or not, and if it was done, repeated or not, and if there is abnormal result, whether the parent informed or not. What is the head circumference? And usually we measure it every week. What's the length of the baby? We usually measure it every week. and whether there is A, B, Ds. A sound for apnea, B for brady's, and D for desaturation. What are the number? How long these events happened? What are the type? Is it A or B or D? And when it happened, whether there is intervention or not, and then the response to intervention. And we'll give you a session about the ABDs and how we treat them. And then you have to mention the respiratory. What is the respiratory rate? Is the baby increased work of breathing? Is the baby on ventilation? Is it invasive or not invasive? And what are the mode? And what are the setting? And what are the measures? Okay, I will teach you all that. What are the mode of the ventilation? What are the setting? And because in the mode there is numbers you set and there is number you read. So you have set and measures. In non-invasive ventilation, what are the level? Okay, how many centimeter of CPAP? And whether these numbers change overnight. How much FiO2, whether change or not change. And what is the saturation? Was it change overnight or not? All list of blood gas, whether it's arterial, capillary, or venous. Okay, that's the types. And then you tell me the pH, PCO2, bicarb, base excess or base minus, and lactate level. Whether chest x-ray was done or not done. Whether lung ultrasound done or not done. And if it was done, what's the finding and who read the finding? In cardiovascular, if there is a UAC, what is the size? How long inside? What is the outside level? What is the age of UAC? Where is the tip? That should be mentioned every day. Why? Because it can be pulled back accidentally. Who approved the central line for central use? What is the connection to the central line? What are the pressure in the infusion pump of the central line? The reason, because once the pressure start to increase from yesterday, because you always to mention to me yesterday and today, that means there is a block. And whether there is Q site in the connection, or what we call it the IV stoppers. And inshallah, when we take care of central line and peripheral line, you will learn about this. Also the UVC. Do you guys know what's UAC and UVC?
No, we don't know.
Umbilical
Umbilical.
arterial catheter and
Central.
umbilical venous catheter. Okay?
Yes.
Okay, same for the UVC, exactly same. Peripheral IV, how many times were inserted? Okay, and what is the age of last one? Any complication, local, what is the pressure in the pump? Also, if there is a PIC line, PICC, or peripherally inserted central line, same. Whether the echo done for this baby, if the baby have PDA, whether not diagnosed or not, whether treated or not. What is the blood pressure? Is it invasive or not invasive? What are the size of the cuff you use? How frequently you measure it? Every 15, every 20, every 30 minutes? Is the baby on inotropes? Do you guys know what's inotropes?
Type of medication group.
It's a medication to increase the tone and the contractility of the heart. So what is the dose and whether it being changes or not? What are the type of solution the inotrope in? Is it D5, dextrose 5? Is it D10? Is it D15? Is it normal saline? Is it half saline? Or so on. Either there is heparin with it or not. Also, you need to mention GI, GU. What are the TFI? What is TFI? Is the total fluid intake. It's the ordered fluid. What is the order in the fluid? And you will see that first day, second day, third day, fourth day, there is a standard order. You and the doctor have to use the same. You cannot change it unless you discuss. So there is standard order you go with, and then you change it depend on the status. You always also have to mention the TFR. What is the total fluid already received? And if there is discrepancy between the TFI and TFR, you have to tell me why there is discrepancy. What are the type of the fluid? If there is electrolyte, and if there is electrolyte, sodium, potassium, calcium, magnesium, then you have to tell me. And then you have to tell me whether the blood electrolyte have been done or not. We have to tell me total parenteral nutrition if the baby is on or not. Okay. Feeding, what is the total amount of feeding? Because there is total fluid and there is IV fluid, and the total fluid is IV, feeding, and also medications. So what are the total? How many times you are giving the feed? What are the duration of the feed? How you are delivering the feed? Is you are delivering by gravity, gavage feeding, or using infusion pump, or using hand syringe? What are the type of milk that you are giving? Are you giving EBM, express breast milk, or DBM, donor breast milk, or you're giving formula? Any supplement extra to the milk, any sodium chloride, any Infacare powder, any HMF, human milk fortifier, any vitamins, any irons, whether the baby is off TPN or on TPN. Is the baby past stool? How many times? What is the amount? And what is the size or the volume? And what's the description? Blood, mucus, and so on. You measure the abdominal girth at the level of umbilicus, and then you compare it with the second day, okay, and whether there is distension or not. How is the umbilicus? Is it dry? It's infected? What's the cord status? What is the urine output? So how you do the urine output? You measure the diaper before and after each change, and the difference in the gram is the number of mil. And then divided by the kg, divided by 24, you get mil per kg per hour. What is the birth weight? You need to mention here. What's the current weight? And whether gain or loss in the last 24 hours. And if it was not done, why? The child is sick, or we are doing IVH bundle. I will teach you later what's IVH bundle. And what's our working weight? What is the weight that used for calculation? And what is our target weight? You need to mention to it. Is abdominal ultrasound being done? What is the genitalia, male or female, and what's the status? And whether the electrolyte is done or not. Hematology, you need to tell me blood culture done or not, how many times, whether it's positive or not negative. Whether CBC done in the last 24 hours, and if not done, what is the last time done? Whether the baby is on antibiotics, what is the dose, duration, and type? Is a transfusion done to the baby? Amount, number, and any complication? Is there is urine culture? Is there a CSF culture, or there is swab culture? Okay, and then you need to tell me whether the parent in the last 24 hours been updated by phone or by meeting, and who did the meeting with them, or who called them. You need to talk with, you tell me the referrals, whether done to this baby or not. Cardiology, nephrology, pediatric surgery, pediatric cardiac surgery, ophthalmology, and so on. And then you tell me your assessment. So this baby is twin. He's premature. He's low birth weight. He has apnea of prematurity. He has feeding intolerance. He's ventilated. What is his saturation? What's his gas? His cardiovascular, what his blood pressure, and so on, your assessment, each system. And then you tell me your plan, what you will do in the next 24 hours. So you'll tell me, I will score the pain, I will do infection control for this baby, I will feed the baby this amount, this duration, this type of milk. What are the bundle? If there is infection control bundle, or there is IVH to prevent. What's IVH? Anybody knows? What's IVH?
Intraventricular hemorrhage?
Correct. So we need a bundle of, I will apply the bundle of IVH. I will teach you later. And then you will tell me these are the order that giving to me, and I'm going to follow. I will give these medications. I will do this blood work, and I will monitor these kind of thing. Okay, and I'm done with first session. I'm going to stop sharing, and I will wait for questions. Whether I was fast, slow, do you have any question? Do you want me to change anything? And please don't consider me a doctor. Just consider me one of your friends. And free with me. I'm only strict in the timing and patient care. Any other things, I'm not strict. So your timing and discipline is very important to me. Patient care is very important to me. Anything else, I don't care about. You can talk to me, you tell me Yahya, you shout on me, You hit me, you talked to me, you talked about me. I don't care. We eat together, we play together, we go outside together, we do everything together. But two things I won't accept at all. Timing, because that's for me discipline, because that's mean life of the patient and patient care. Any other things, I'm open. So any question, any comment? Any question, any comment? How's the session was? So let's stop recording.